Hello and welcome to Raven Medical's video presentation for our blended Advanced Workplace First Aid Training program. As you know, most of the required content for the Workplace First Aid Training is covered in the Wilderness First Responder. However, there are a few topics that are required in the workplace training that are not covered in our WFR course. This presentation will review these topics and provide some workplace-specific information for the province of Alberta. Once you have reviewed this and the other modules, you'll be able to write the exam for the blended certificate. Here's a quick overview of the topics in this presentation. There are 3 medical conditions that need to be discussed. First, we'll review congestive heart failure and chronic obstructive pulmonary disease. Another topic not covered in all our WFR programs is general information on poisons. In the second video presentation, we'll move on from these medical topics into some workplace-specific details. The first topic is a discussion regarding the workplace requirements for assisting with medications and not administering them ourselves. Next, we'll review the required contents of the 3 levels of workplace first aid kits. And finally, we'll discuss how to clean and manage first aid equipment in the workplace. So, let's get started with the chronic medical problems not discussed on a WFR course. The first medical condition we're going to discuss is congestive heart failure. The best place to start is to review the anatomy. The heart can be divided into 2 sides, left and right. If one side of the heart becomes damaged or weak, it cannot keep up with the other side. The right side of the heart receives blood from the body and pumps it to the lungs. The left side receives blood from the lungs and pumps it out to the body. So let's say the left side of the heart is damaged and weak. The healthy right side pumps lots of blood to the lungs, but the left side cannot manage that volume because of the damage. Unfortunately, the blood backs up in the lungs. This backup increases the pressure in the lungs, and fluid leaks from the blood vessels into the alveoli or air sacs. This is called pulmonary edema. The lungs start to fill up with fluid, hence the name congestive heart failure. The lungs are congested with fluid. Alternatively, if the right side of the heart is weak and it cannot handle the blood volume returning from the body, a similar process occurs and the blood starts to back up, but this time it's in the extremities, generally the legs. As the blood pressure increases, the fluid shifts from the blood vessels into the lower legs and we get swollen ankles and lower legs. This is edema. Now we know what it is. You need to know who's at risk for congestive heart failure. CHF is a chronic and progressive disease that generally is seen in older adults with other chronic conditions such as diabetes, high blood pressure, obesity, respiratory, or other heart problems. Other risk factors include smoking, alcohol consumption, and a family history of heart disease. So now we understand some of the physiology of CHF, let's look at it from a first aid perspective. As in your WFR course, we will use the ATP, or Assessment, Treatment, and Plan structure for this information. Assessment. Congestive heart failure generally presents with shortness of breath or respiratory distress. The patient will be sitting upright and not wanting to lie down. Generally, they'll complain of fatigue and possibly chest pain or anxiety. From a physical assessment perspective, the patient could be pale, gray, or blue, what we call cyanotic. Listening to their breathing, you could hear crackles or wheezes. It sounds like very wet respirations. Examining their lower legs, you'll see swollen feet and or ankles. Their vital signs will include an increase in pulse and blood pressure. If you have an oxygen sat probe, you could see a decrease in their oxygen levels or their SpO2. The final piece of assessment is the sample history. CHF is a chronic disease that develops over months or years. The patient will have a diagnosis of CHF, and they're generally aware of this condition and that currently they're experiencing a worsening of their symptoms. Other pertinent findings in the history is that these patients will be on one or more often many heart medications. To review our assessment, patients with a known history of CHF and are experiencing a worsening of symptoms will complain of fatigue and shortness of breath. They could be coughing and generally will want to sit bolt upright. Their legs could be significantly swollen and their vital signs will be elevated. Let's move on to the treatment and planning for CHF. CHF patients need medical attention. Workplace first aid treatments involve supportive care. Our general treatment for respiratory distress is great. PROP. Position for easy breathing. This will involve transporting the patient to medical care in a sitting position with very little physical effort on the patient's part. Reassure the patient. Remember to keep them calm and reduce the demand for oxygen. Oxygen is good for these patients. High flow oxygen through a non-rebreather mask is indicated. And a patient may require ventilations via bag valve mask if they start to deteriorate into respiratory failure. Finally, if the patient has their own nitro spray, you could consider assisting them self-administering nitro to the maximum dosage that they are prescribed. The planning for CHF is straightforward. Transport to medical care. The level of urgency is based on their symptoms. Remember that these patients will not get better on their own and they need medical care. Any serious signs or symptoms require urgent evacuation. Consider asking for advanced life support rendezvous if it's available. Paramedics have several treatments for CHF that can really help to stabilize the patient. This was a quick overview of congestive heart failure. Remember, if you have a patient with a history of CHF and is short of breath, they need to go to the hospital. Oxygen and supportive care are your main treatment options. From here, let's move on to chronic obstructive pulmonary disease, or COPD. COPD is the third leading cause of death by disease in the USA and Canada. Let's start by reviewing the respiratory anatomy. Recall that the lungs are made up of a complex network of tubes, much like the root structure of a tree. These tubes, or bronchioles, carry air from the mouth to the small air sacs, alveoli. The alveoli are clustered around the ends of the terminal bronchioles and wrapped in blood vessels. This is where the gas exchange occurs. COPD is a group of chronic lung diseases, but has two main types. Chronic bronchitis is a long-term inflammation of the bronchioles. This inflammation leads to an increase in mucus production and a thickening of the bronchial wall. With thick tubes plugged with mucus, it is very hard to move air in and out of the lungs, making it much harder to breathe. The second type of COPD is emphysema. This affects the air sacs and the walls between the individual alveoli. Over time, the walls break down and become less elastic, resulting in less surface area to exchange gases, and a much stiffer lung increases the work of breathing. The main risk factors for COPD is smoking. However, other risks include occupational exposure to low levels of toxins, lack of physical activity, age, and obesity. COPD is not found in patients under 40 years of age. How do you assess a patient for COPD-related problems? When a patient's COPD is starting to get worse, or what is called exacerbation, they will complain of worsening shortness of breath. A patient with COPD will have chronic challenges breathing, especially with activity, but they will reach out for assistance if it's getting more challenging than normal. Their work of breathing is obvious, and they may have a productive cough. A physical exam will reveal noisy breathing, either wheezing or wet lung sounds. When assessing vital signs, an elevated pulse and respiration rate will be found. As well, the patient could be pale or gray in color. If you have a SAT probe, the oxygen level will probably be low, below 92%, and frequently found in the 80s. Finally, these patients could be fatigued and starting to decrease their mental status. They could be more confused or very slow to respond to questions, as the work of breathing has made them very tired. As with CHF, their sample history will find a history of COPD with a number of medications and puffers. From a first aid perspective, again, all we can do is our standard treatment for respiratory distress and arrange a quick trip to medical care. Again, we prop the patient in respiratory distress. First, positioning the patient. COPD exacerbation patients will be sitting upright and will not want to change from that position. Reassurance is important. Struggling to breathe can make a patient very anxious. Oxygen is good, but ideally we'd have a SAT probe to monitor their blood oxygen levels. In the case of COPD, we'd ideally keep their SAT around 92%. Don't provide high levels of oxygen if their SAT is over 98%. If you do not have a SAT probe, then administer oxygen via nasal cannula and slowly increase the flow until the patient gets some relief. This may take 3 to 5 minutes to take effect. As usual, we only consider PPV if the patient is starting to show signs of respiratory failure. Patients with COPD have some medications that could help them. Follow your assist with medication instructions and assist the patient in taking their own puffer medications. Once you've started treatment, transport to medical care is necessary. The level of urgency is based on the severity of symptoms. If the patient is mildly short of breath, then non-urgent transport is reasonable. Monitor the patient closely, as COPD patients can tire easily and would deteriorate faster than you think. If the patient is working hard to breathe, then urgent transport is required. As well, if possible, arrange for advanced life support to attend the patient during the transport. The next topic that needs to be discussed is poisons. Poisons are substances that cause harm to organisms when sufficient quantities are absorbed, inhaled, injected, or ingested. A toxin is a poisonous subject produced within a living cell or organism, and venoms are a mixture of various toxins. In the WFR program, we addressed wilderness-specific toxins, i.e. snake and/or animal venoms. Workplace first aid has a much higher risk of exposure to a wide range of poisons. Potential poisonous substance in the workplace could have one of the following labels. There are 3 WHMIS labels that identify poisons. First is the exclamation mark, which is used for hazardous products that could cause less serious health effects. These poisons could cause acute toxicity, skin irritation, eye irritation, or respiratory damage on a single exposure. The second symbol is the health hazard pictogram. These products cause serious health effects. And finally is a skull and crossbones, which identify products that can cause death or toxicity with a short exposure to small amounts. Poisons have 4 means of entering the body. Each of these exposures have their own risks and required specific treatment. The 4 routes of exposure are: absorption is a poison that enters your body from contact with the skin. Ingestion is a poison that is absorbed from your stomach and digestive system. An injection is a poison that enters the body after being injected under the skin. And finally, inhalation is a poison that enters the body via the respiratory system. Now that we understand what poisons in the workplace are and how they can enter the body, let's move on to the general concepts of managing a patient exposed to a poison. There are 4 main objectives in managing a patient with a potential poisoning. First is to remove the hazard. This may involve moving the patient to an area with clean air or decontaminating the patient. You, as the rescuer, need to be safe, so remember, always wear appropriate PPE before entering a potential toxic area. The second goal is to identify the toxin. This can be the most important job for a first aider to perform. While at the scene, first aiders have access to identify the substance or suspected substances. As well, asking questions provide critical information for the patient care in the hospital. A patient may become unconscious by the time they get to the hospital, so first aiders could have a brief window of opportunity to ask questions and help identify the poisoning. The third goal is to access the safety data sheets. This will have good first aid information and critical substance identification to guide the hospital treatment. Finally, the fourth goal is to provide first aid treatment and prompt transport based on the SDS and according to the signs and symptoms observed. The most important aspect for poisoning assessment is to gather information. Ask lots of questions early in your assessment, as the patient may become unconscious later on. I would start my secondary assessment with a complete sample history. Assess the patient's current symptoms. What are they complaining about? Make sure you ask the patient about allergies and current medications.
Moving on, asking the patient about their medical conditions and other pertinent history is important because some substances will affect individuals differently due to their underlying medical conditions. As well, ingested poisons may interact with various medications differently. Last ins and outs might not be as important as other sample questions, but it's always good to know that the patient has been eating and is well hydrated. Moreover, a patient who is vomiting or having diarrhea are very important symptoms of some poisonings. The most important aspect of the sample history is the events. Determine facts such as route of exposure, time of exposure, quantity of poisoning substance. Gather pill bottles or other containers at the scene and send to the hospital with the patient. Do not send chemical containers to the hospital. In that case, grab a quick photo of the potential chemicals or various chemicals at the scene. In addition to the SDSs, a few quick photos can go a long way in answering doctors' questions when you arrive at the hospital. Think about questions such as, were there multiple substances involved? Was the patient drinking alcohol? And as always, part of your assessment is to gather the safety data sheets for any potential chemical. Moving on to the physical exam, it's important to ensure that the patient is decontaminated before you examine them closely. If the patient was exposed to an absorbed poison, note the area of body contact. Look for redness, swelling, or damaged skin. Also note the size of the affected area. Getting a baseline assessment of the size will help to see if the damage is spreading. Finally, make sure you get a complete set of vital signs. As with other assessments of poisoning, a baseline set of vitals could be valuable for the paramedics or hospital providers. Treatment for poisoning is primarily symptom-based. Treat what you find. As always, the SDS will have specific first aid treatment for individual poisons. The patient should have been decontaminated as part of the scene survey, but make sure the patient does not pose a risk to the rescuer. Here are some general guidelines for treating poisons. If it is a dry powder, brush it off and remove the patient's clothing. If it's wet, flush with lots of water for at least 15 minutes and remove the clothing. Treat what symptoms you find. If the patient is struggling to breathe, follow our general treatment for respiratory distress, PROP. There are two more general recommendations. First, don't induce vomiting or give anything by mouth. The only exception to this rule is if there are specific directions on the SDS. As always, follow the SDS first aid instructions. One final treatment consideration is that if the patient was exposed to carbon monoxide or other airborne toxins, then always administer oxygen even if the patient is not short of breath. Once we've initiated our treatment, we have to figure out what we're planning to do with the patient. Patients with toxic exposures always need medical attention. As it's difficult to anticipate what may develop with a poisoning, urgent evacuation is generally warranted. Just make sure that you have all the information with the patient. Pill containers, photos of chemical containers, SDS sheets, and any other details of the scene. This wraps up part 1 of our additional material for the Advanced Workplace First Aid Blended Certification Program. When you're ready, please feel free to move on to part 2 video presentation. Thanks for watching.